and the prosecutors are present as well. You guys ready for the jury?
Yes, sir. Sure.
Okay, let's bring him in, please. Please be seated, everyone. Dr. Hanlon, I remind you that you're still under oath, okay?
Yes, sir.
All right. Mr. King, you may proceed with your direct examination.
Thank you, Your Honor. Doctor, before I move on, I just want to talk briefly about a couple things that Mr. Brockler brought up. First of all, were you previously qualified as an expert in this case, in a previous hearing to testify in this case as an expert?
Yes.
Did the fact that you are invited to do lectures by a public defender organization or some organization affect in any way the way you administer neuropsychological tests?
No.
Now, and I want to talk a little bit more about this later, but are neuropsychological testing such that you have to administer the test correctly and the subject answers the questions of the test, and the results of the test are the results of the test? Do you create the results of the test, or do the results speak for themselves?
Well, the results, the responses to questions or the task that is being requested or elicited are it's based on the examinee's response, and I don't change that.
Does Mr. Brockler asked you about the different types of cases you've been retained on, and who's retained you, and whether they took place before a conviction or after a conviction, or whether they were related to homicide or not to homicide, or to death penalty cases or to not death penalty cases. Do any of those considerations have anything to do with the way that you administer, score, or report the results of your psychological testing?
No.
Now, to be fair, I asked you some question about how many mass murder defendants that you had done neuropsychological evaluations of. And you recall that exchange that we had, yes?
Yes.
And Mr. Brockler asked you a series of questions where he had you break down the categories of the 27 different mass murderers that you have conducted neuropsychological evaluations of. And they were broken down into different categories by the motive that was related to the crime. Do you remember that series of questions?
Yes.
That some of them were domestic violence situations or in the family Holmes situations. Remember that?
That's correct.
That some were motivated by murders committed in the act of committing another crime, and that was the motivation. You remember that?
Yes.
And some were crimes that were, you said the cutting out of the baby case that was motivated to have another baby or something like that. Is that right?
Yes.
And basically all of the cases, Mr. Brockler had you categorize them in the category of what the motive was, and said, well, none of those apply to this case. Do you remember that line of questioning?
Yes.
Let me ask you this. How rare is a mass murder case like this, where there is no motive for the crime?
Sustained. You can rephrase the question.
How rare is a mass murder like this that won't fit into one of those categories that Mr. Brockler had you put your cases into?
From my review of criminologic literature and crime analyses of mass murders, it's extremely rare.
Has anyone that you're aware of done a neuropsychological evaluation of a defendant in a case like this?
Not that I'm aware of.
So you haven't done it, and neither has anyone else.
As far as I know.
I want to talk to you a little bit about your involvement in this case, if I may, sir. And how did you come to be involved in this case? Did you contact us, or did we contact you, or how did that work?
You contacted me.
Before you were asked to conduct, or before you conducted your neuropsychological examination of Mr. Holmes, were you given some information by my office to review at your request?
Yes.
What information were you provided?
I was provided with the jail records from the Arapahoe County Detention Center. I was provided with some educational records. Some records regarding family history.
How about academic records of Mr. Holmes, like his transcript from the University of California, Riverside, or from CU?
Yes, I was provided with those educational records.
How about the records of Dr. Fenton and Dr. Feinstein and Margaret Roth at the treatment he received at Anschutz?
Yes, I received those records.
How about did you say the jail records from the detention facility?
Yes.
how about the records from the doctors, the psychiatrists that treated Mr. Holmes at the Denver Health Medical Center in November of 2012?
Yes, I received those.
Did you get his school records from middle school, high school?
I did.
Is it important to you, like school records, because it has some reflection of cognitive ability, how somebody does in school?
Yes, they're very important.
Were you provided or not provided with, like, police reports in the case?
I don't know if the police reports were in the original document set that I received, but I did eventually receive some police reports.
And was it necessary for you to review all of the police reports and all of the information in the case in order for you to conduct the neuropsychological testing that you did?
No.
And are you did you review all of it?
No.
Now, was your understanding of what you were tasked to do, and when was this that you were contacted and conducted your neuropsychological examination?
I conducted my original neuropsychological evaluation of Mr. Holmes in April of 2013, I believe, over the course of 3 days, April 18th, 19th, and 20th of 2013. When I was contacted, I believe, maybe it was either very late in 2012 or January of 2013.
Okay. And what was the understanding of what you were tasked to do?
What I was asked to do very specifically was to conduct a neuropsychological evaluation of Mr. Holmes that would be specifically a thorough, detailed assessment of his intellectual functions and his cognitive functions.
Were you asked to diagnose what his medical condition, mental health condition was?
No.
Were you asked to render opinions about whether he was sane or not at the time of the offense?
No.
Were you asked to determine when and if he was psychotic and how?
No.
Were you, in that regard, did you review his writings, for example? Were you given the copy of his notebook to read?
No.
Were you given emails, exchanges between him and his friends or his family to review, or computer searches that he'd done on his computer, or text messages that he had sent? Do you remember?
No, not at that point.
Is in your opinion, your expert opinion, is any of that information important or relevant to the what you were tasked with doing, the limited task that you had?
No, not at the time of my original evaluation. Those documents, that information, certainly was not imperative for me to review.
Now, you said earlier on this morning that you're qualified. You're a psychologist, right? And your specialty is neuropsychology. Fair to say?
Yes.
So you're certainly qualified to administer the type of personality inventories or psychological testing. For example, like Dr. Gray did in this case, MMPI, PAI, those types of tests. Is that right?
Yes.
And what's the difference between neuropsychological tests and those kind of psychological personality tests? What are they meant to learn? Are they meant to learn different things about a person?
Yes, they're designed and intended to assess different mental functions and make determinations about different aspects of mental status. Neuropsychological evaluations are, in the purest sense, intended to objectively assess cognitive functions and intellectual functions, and sometimes motor, sensory motor functions as well. But fundamentally they are designed to assess mental abilities, whereas psychological testing, similar to what Dr. Gray did, those are what are called psychodiagnostic types of tests. They are designed to assess personality features, personality traits. They're designed to assess psychopathology or mental illness. So, for example, depression or anxiety or psychosis.
So in that regard, and you said you listened to Dr. Manguso's testimony yesterday, in that regard, was your role in this case kind of identical to the role of Dr. Rose Manguso in that it was limited in that way?
Yes, it was very circumscribed, it was very focused, and it was made, and it was very clear to me what my role was.
Have you had a chance to, have you exchanged data and information with Dr. Manguso and discussed the findings that both of you had between each other?
Yes.
Is that normal for psychologists and psychiatrists to do, to confer between each other and discuss the issues?
It's very common in clinical, with clinical patients. It's a very common interchange. It's not as common in criminal forensic cases, but it did happen in this case.
Okay. Did you conduct a clinical interview as part of your testing in this case?
Yes.
Or in conjunction with it?
Yes.
And why? Was it your suggestion that needed to happen?
Yes, it was.
Was that a requirement that you put on the conditions of you conducting the neuropsychological testing?
Yes.
And why is that?
Because it is an important part of a neuropsychological evaluation. Sometimes doctors who refer patients for neuropsychological evaluations, and sometimes lawyers who refer defendants or plaintiffs for neuropsychological evaluations, sometimes think or want just testing to be done and nothing, and they seem to think that someone like me is going to do nothing else. But it is important, and I think any neuropsychologist would agree that it is imperative to conduct a clinical interview in order to obtain information that needs to be factored into the interpretation of the neuropsychological test results, such as developmental histories, social history, educational history, medical history, etc.
Does that also include issues that may surround the testing itself, like whether the person is ill at the time or tired or medicated, or do you have to ask those kind of questions in order to take those things into consideration?
Absolutely.
And the clinical interview that you conducted, was it limited in scope?
It was limited to the information that I believed was necessary for me to know in order to complete a good, thorough neuropsychological evaluation of him.
Okay. And again, you heard about the clinical interview that Drs. Manguso and Gray did together, right?
Yes.
Was your clinical interview even more narrow than theirs was in ways?
Yes.
So they covered areas that you didn't even go into?
That's true.
Did you ask any questions about the crime, for example?
No.
Did you ask any questions about the events leading up to July 20th, 2012, or what Mr. Holmes was thinking during that period of time?
No.
Were you concerned at all about about those issues surrounding that period of time, or is that just not important for your consideration, given the limited scope of your role?
there was not information that was necessary for me to acquire from Mr. Holmes in order to conduct the evaluation that I was charged with conducting.
Okay. Did I indicate to you what I wanted the results to look like, or did I direct how things should come out in any kind of way for you, or did I just say, were you just instructed to do your testing and let us know what the results were?
You gave me no instruction. You gave me no expectations. You quite bluntly asked me to conduct a neuropsychological evaluation of the defendant, and I told you what I planned and what I was going to do in terms of completing that evaluation, and that was in essence the extent of our exchange.
Okay. And if you didn't feel like that it was appropriate way to proceed, would you have either said no or told me what needed to be different, like you did with the clinical interview?
Yes, I would have told you what I required, and if you didn't agree to that, I would not have conducted the evaluation.
And is that because as a professional you need to make sure that your results are accurate and that you do things appropriately?
Yes.
And well, let me ask you this. Did you prepare some slides for us to help aid in your discussion today of the examination you did of Mr. Holmes?
Yes.
May I have slide number 2, please? Your Honor, may I publish some of the demonstrative slides?
Yes.
With your permission?
Yes.
Sir, what kind of, you heard Dr. Manguso's description of what a neuropsychological examination is and what some of the tests were yesterday. Is there anything that you wanted to add or you thought was important? I don't want to rehash all the same stuff. Is there anything you want to add or think is important about how the tests are administered or scored, or whether the objective nature of the testing? Or do you think she covered it pretty well?
I think Dr. Manguso did a fine professional description of what constitutes a neuropsychological evaluation. I think she outlined the different domains as they are outlined in this slide. Maybe the one domain that I don't recall Dr. Manguso mentioning was social cognition, and that's not always a component of a neuropsychological evaluation, but more and more frequently it is becoming a component of a neuropsychological evaluation.
In this slide that we're looking at here, are those the various domains of cognitive functioning that you set out to test Mr. Holmes for?
Yes.
How do those relate to, do those all relate to the way people think?
Yes.
How does social cognition fit in there? You just brought that up.
Social cognition is an area of mental ability that involves how people think in social interactions. And for example, it involves the perception of facial expression and being able to perceive or differentiate an angry facial expression from a happy facial expression or a sad facial expression. Those are just some examples. That's one example of social cognition. Also involves things like tone of speech, being able to differentiate sarcasm, for example, from just honest, straightforward, direct response to a question.
The instruments that you chose to administer, and I want to go through them a little bit, but who chose the test? Did you choose the test, or did we tell you what tests that you needed to do?
I chose the tests.
Did you choose the exact same test that Dr. Manguso did?
No.
Okay. Were they similar? Can you tell us what the difference was or what the similarities were?
They are similar tests in that they're both tests. They're both tests that constitute different what's called a neuropsychological battery of tests. And as Dr. Manguso stated yesterday, she was somewhat constrained by the fact that the defendant had already undergone a neuropsychological evaluation 4 months before she evaluated him. So she didn't want to use some of the same tests that I had used because he had previous exposure to them and would remember them. So, for example, Dr. Manguso did not assess intelligence in Mr. Holmes. She did not do testing to produce an IQ. But she did do memory testing. She did testing of attention, concentration. She did testing of language, perception. She did some testing of constructional abilities. She certainly did executive functions, and she did some of the same tests of executive functioning that I had done previously. She did assess reasoning. She didn't really, I don't recall, assess any aspects of social cognition. And, like me, she is very rigorously assessed symptom performance and validity.
Thank you. Can I have slide 3, please? When did you do the examinations of Mr. Holmes, and where and when did you do them?
I did the first neuropsychological evaluation of Mr. Holmes in April of 2013 in 3 consecutive days. They were conducted at the Arapahoe County Detention Center next door. And so over a period of 3 days, I spent 13 and a half hours primarily testing him. It was maybe an hour to an hour and a half what constituted the clinical interview. And
then you did a second neuropsychological evaluation?
Yes, and there was a second neuropsychological evaluation done in January of 2015 in 2 consecutive days, January 5th and January 6th. Also done at the Arapahoe County Detention Center next door. And
Dr. Manguso testified some about this, but is it a good idea to do, over time, to do testing again at a later period?
It is. It's a common practice. There are many psychiatric and neurologic disorders which serial or series of neuropsychological evaluations are required to objectively assess change over time. I mean, it's commonly done in the dementias, Alzheimer's disease, vascular dementia, et cetera. It's also done in traumatic brain injury. It's also done in conditions in psychiatric disorders, particularly when there's treatment intervention.
You heard Dr. Manguso's testimony yesterday where she said that in her testing there was some very slight cognitive impairment in some of the testing that she did. Do you remember that?
Yes.
And Mr. Brockler made a point to bring out that it was slight impairment and not a dramatic impairment. Fair to say?
He did.
Is that something that you noticed when you got the results of her examination?
I did. When I received Dr. Manguso's report, I was very clearly aware that she had determined that Mr. Holmes, in the testing that she did, showed evidence of very mild, subtle neuropsychological deficits or cognitive deficits, which was different than my original evaluation, in which he showed no evidence of any neuropsychological or cognitive impairment. So that was a difference. There was really only 4 months in between those two, my first evaluation and then Dr. Manguso's evaluation. And so there appeared to be, again, slight, minor, subtle change.
Is that one of the reasons why you thought it might be a good idea to do another evaluation?
Sustained?
Was that or was that not one of the reasons why you thought it was a good idea to do another evaluation?
Yes, that was definitely one of the reasons that a second evaluation was considered, in that he had shown some evidence that there were differences between the original evaluation that I did and the second evaluation, or the evaluation that Dr. Manguso did. And
that second evaluation took place earlier this year, is that right?
That's correct.
Why was that one shorter? By 2 hours, 2.5 hours, I guess.
It is a little shorter because there were a couple of areas that I really did not think it was necessary to retest him on. I did not, for example, do any reassessment of social cognition.
Okay. So let's go through some of the testing that you did do, and I want to start out with validity testing, if I could do that. Could I have slide 4, please? Now, what is validity testing, and why is it important, sir?
Validity testing, as shown on that slide, just to be blunt about it, is our testing done with the attempt to rule out or determine if an individual is exaggerating symptoms, if they're feigning symptoms, or if they're just flat out malingering. These are crucial tests that need to be included in any neuropsychological evaluation, whether it be for a forensic or the criminal defendant or even a clinical patient. It is imperative. It is extremely important for a neuropsychologist to be able to conclude that the test data are valid, they're representative of the status of this individual at this time. And so that's why these kinds of tests are administered.
Okay. And on this graphic, can we call out, ma'am, the first part, the performance validity part, including the dates, if that's possible? Including the dates, if that's possible. Now, in this graphic, thank you, ma'am. In this graphic, 413, is that your first set of testing?
Yes.
813, is that Rose Manguso, Dr. Rose Manguso's testing?
Yes.
And 115, is that your second set of testing?
Yes.
And 714, what does that represent?
That represents the second evaluation that Dr. Gray did. Dr. Manguso, my understanding, did not do any further neuropsychological evaluation at that time. It was only Dr. Gray.
And is that why that's blank? Because there was no neuropsychological evaluation done at that time?
Right.
So it looks like you only have two tests that Dr. Manguso administered in August. Did she administer more tests? Are those just the ones that overlap with yours? Of symptom validity, I mean? Or do you not recall?
Those are
in other words, she didn't administer the word memory test, the Victoria symptom validity test, the B test, the reliable digit span, or the California verbal learning test, did she?
Actually, thank you for asking that, Doctor, and I apologize. I've omitted a score from Dr. Manguso.
Okay.
She, in fact, did administer the B test, and that score should be there. That would be another 1. So as she testified yesterday, she did in fact administer 3 different performance validity tests: the test of memory malingering, the validity indicator profile, and the B test.
Did you just call me doctor?
I'm sorry, did I? No offense.
I'm getting used to that. Tell us about the validity testing that you did, sir. Did you do the TOMS like she did?
I did.
And what was the result of that?
The TOM was, he performed, I believe, perfectly. I think he did 100% accuracy. I can check and, well,
Feel free to check if
I
you
can
want.
easily check and see.
Are you looking at your report?
I'm looking at the addendum to my report, which is a data sheet.
Thanks, sir.
Yes, in the April 2013 evaluation, he scored at the 90 on the first trial there are 3 different trials. And this is looking at different pictures and being told to remember them. He scored at the 94th percentile, or 94% accuracy on the first trial, 100% accuracy on the second trial, and 100% accuracy on the retention trial.
Now, the fact that one was 94, what's the significance of that?
It was the first trial. There is no significance. It's still well above any cutoff to suggest that it's anything but sufficient effort.
How about the Green's word memory test, the first one up there then?
The Green's word memory test, he also scored at a very high level, demonstrating no evidence of symptom exaggeration or feigning of memory.
Validity indicator profile test?
Same thing as he had done with Dr. Manguso, and the scores were almost identical between my first evaluation and Dr. Manguso's evaluation. His score was valid and compliant.
And anything significant about the remaining tests that we should need to talk about?
The one significant point about those last 2, that are the reliable digit span and the California verbal learning test, those are embedded. They're what they're called embedded performance measures, meaning that they're not separate tests that are designed to assess for effort or faking. They're subtests within other neuropsychological tests that are used to determine if the individual is putting forth sufficient effort or faking in the context of that particular neuropsychological test.
So I don't understand you have 40 subtests over there on the right, in the right margin. What's that mean?
That means that collectively, from all these different, the separate neuropsychological evaluations that Mr. Holmes underwent, he consistently, there were 40 different subtests that assessed his effort, his whether or not he was putting forth optimal effort, or whether or not he was exaggerating anything. He passed them all 100%, 40 out of 40.
And that includes your testing and Dr. Manguso's testing?
Correct.
Do you have an opinion then about whether Mr. Holmes put forth solid effort and was not feigning or malingering any of his cognitive deficits or anything like that?
I believe that he consistently put forth optimal effort, and he showed no evidence whatsoever of feigning or faking or malingering on any of the neuropsychological evaluations that were completed.
Okay, thank you. And if we could now call out the bottom part, if ma'am. Now I want to be clear, because I don't want to, the MMPI-2 and the PAI, you didn't do those, did you?
I did not.
And that's why the columns where your testing is blank, is that right?
That's right.
Is that testing that was done by Dr. Gray and Dr. Manguso told us about some of that yesterday. Is that right, the results of that testing?
Yes, she did.
And what's the SIRS there? It looks like you gave the SIRS on the 15th of January. What's the SIRS?
The SIRS is a structured interview that is, it's a very good test, it's a very sensitive test, and it's used to evaluate whether a examinee is exaggerating psychiatric symptoms, particularly psychotic symptoms.
How's that different from the other test you gave up above, the performance validity tests?
The performance validity tests are all designed exclusively to assess for performance on cognitive tests, and whether somebody's putting forth effort or not. The symptom validity tests they're different in that they're really not looking at cognition or mental abilities. They're looking at whether somebody is over-endorsing or exaggerating psychiatric symptoms, and in the case of the SIRS, particularly psychotic symptoms.
So to put it in lay terms, is the difference between faking not being able to think right and faking being psychotic or having a mental illness?
Yes.
And what was his performance on the SIRS? How did he perform on that test to evaluate whether he was malingering psychiatric symptoms?
Well, during the testing by me in January 15, as well as in the testing by Dr. Gray in July 14th, he passed all of the scales on the SIRS and showed no evidence of psychiatric symptom exaggeration or malingering, and he wasn't even close.
So based upon your testing that you did and your information that you have an opinion about whether Mr. Holmes is faking a psychiatric illness based on what you know?
Based on the testing that I've done, based on the testing that Dr. Gray did, Dr. Manguso did, he consistently shows no evidence of just even exaggerating symptoms, let alone malingering.
Thank you. Let's talk a little bit more about some of the other, and you can take that down, thank you. Some of the other neuropsychological testing that you did. Did you do tests that related to attention?
Yes.
The Connors Continual Performance Test, what's that?
The Connors Continuous Performance Test, second edition, is a test that I administered to Mr. Holmes on both occasions, both of my evaluations. It's a test of attention and also includes reaction time. It's a computerized test, and he consistently scored within the average range, even above average range. On that test, his reaction times were quite good. Actually, his reaction times were faster the second time that I administered that test to him.
Okay. So consistency between the two sets of tests?
Oh, very consistent.
How about the trail making test? I think that Dr. Manguso did that one too, did she not?
She did.
And what was the result on that?
The trail making test is a test that consists of two parts, and there is the first part, and I think Dr. Manguso testified about the part A yesterday, which is a very simple, basic, straightforward test of speed of information processing. It's basically a connect the dots type of a paradigm, and with me, he scored in the average range. The first time I evaluated him, he scored in the average range when she evaluated him, and he scored again in the average range when I evaluated him the second time.
Pretty consistent.
Yes.
Did you do what was your general conclusions then about attention?
His attention as assessed on those types of tests that you just questioned me about, he showed no evidence of any attentional disturbance or dysfunction.
Okay, so he's got no problems with his memory.
He has no problems with his attention and his concentration. In that respect.
Concentration, okay. How about language? Did you do any neuropsychological testing that related to language?
Yes.
Is that the NAB naming test that helped with that, or no?
Yes.
How did you do on that?
He scored in the average range.
Okay. How about the verbal fluency test?
The verbal fluency test is a test, again, Dr. Manguso mentioned this yesterday. It's a language-based test, but it also does assess a specific aspect of executive functioning, as I believe she mentioned, mental fluency of thought. And he scored in the average range when I evaluated him the first time, and actually did a little bit better on that test the second time I evaluated him.
So fairly consistent there.
Yes.
And the wide range achievement test, was that similar, or?
The wide range achievement test is a test of reading, and well, there are several parts to it. The parts that I assessed with Mr. Holmes involved his reading accuracy, meaning his ability to just look at a word and read it, so break it down in terms of the sounds that the word is based on, and then also reading comprehension. And he scored in the high average range in both of those aspects of reading.
So fairly consistent?
Yes.
Fairly intact?
Intact.
And what, by intact, what do we mean in your parlance, in your line of work?
Intact is that's a good question.
I'm a doctor, that's why I ask such good questions.
Intact often is interpreted by neuropsychologists that if someone is performing scores in the average range or high average range or superior range or very superior range, typically that function is going to be interpreted as intact. That doesn't mean that it may have declined from a previous higher level of functioning, but it's not impaired. It is still intact, and you can also talk about some scoring within normal limits, but that's generally what intact refers to.
Okay. I think we finished up with language then. Generally intact. How about visio-perceptual and constructional abilities?
Yes.
Judgment and line orientation test, does that relate to that domain?
It does.
And how did he perform on that, sir?
On the judgment of line orientation test, that's a test where he has to look at lines that are presented at different angles and determine the spatial position and orientation of those lines. He scored in the average range the first time I saw him. Then later during the second evaluation, he had declined a bit and scored in the low average range.
Okay. The first, so would you describe it as intact the first testing and not so intact the second testing, or how would you describe it in your expert opinion?
Yes, I think it was intact when I evaluated him in April of 2013. In January of 2015, he's still scoring within normal limits, but his performance had declined. And so it didn't represent an impairment, but it did represent a change in his performance and ostensibly his functioning in that domain of cognition.
Just so that we're clear, is it your opinion that he was still functioning basically normally in that domain, but slightly poorer than he had when you tested him the first time.
That's fair.
Am I saying it correctly?
That's fair.
Let's talk now about executive functioning. You heard Dr. Manguso describe the prefrontal cortex yesterday and the executive functioning. Did she do a good job describing what executive functioning is and how it works?
Yes, I think she did. Executive functions are typically and clinically associated with the frontal lobes, the frontal cortex, particularly the prefrontal cortex. That doesn't mean that that lesions and or damage in other parts of the brain cannot produce executive deficits. That can certainly happen. The brain is a system, and there are connections. The different areas of the brain are all connected. So there you can see a lesion in another part of the brain that may produce an executive function. But classically, executive functions such as problem solving, decision making, reasoning, controlling impulses, are your mental flexibility. Those are to a large degree controlled and processed by the frontal cortex, particularly the prefrontal cortex.
And suffice to say, are the lower areas of the brain, the brain stem and the lower portions of the brain, the more kind of primitive reptilian part of the brain, and then the upper layers and the frontal layers are the more developed layers, if you will?
Yes, they are. Interesting that you use the term reptilian. That is certainly a model that many people believe. But yes, the brainstem is considered to be a very old part of the central nervous system of humans. Yes, it is involved in heart rate and breathing and basically survival processes.
How about like fight or flight in reflexes or something like that? Where would that come from?
You get to a little higher level when you get to those kinds of functions. You get into an area called the diencephalon, which involves structures like the thalamus and the hypothalamus and the amygdala and structures like that.
Okay. Can I have slide 15, ma'am? Can you talk to us a little bit about your testing results with regard to executive functioning, sir? And I don't need to walk down through all the tests with you unless you want me to, but can you just give us a brief discussion of this?
Sure. As you can see here, there are tests that were administered by both Dr. Manguso and myself, particularly, first of all, as Mr. Brockler questioned Dr. Manguso yesterday about the Wisconsin card sorting test.
Is that the one she said was her favorite test or something like that?
I think Mr. Brockler may have alluded to that might have been her favorite test, but I think she agreed to that. Or it's one of the most widely used tests of executive function by neuropsychologists in the world.
Okay.
And it is probably the most researched test of executive functioning on the planet.
Okay.
So it's a very, very good test. It's a very sensitive test. And Mr. Holmes scored very well on it every time it was administered to him. He scored in the average range at the first time that I administered it to him. When Dr. Manguso administered to him, he actually scored a little bit higher, primarily, I think, as she said yesterday, and certainly I would agree with her, due to practice effects that he had previously been exposed to this test and had experience with it.
Let's talk very briefly about that. What is a practice effect?
A practice effect is a phenomenon that occurs when an individual has a test has been administered to someone, and then at a later point in time, that same test is administered again. And it is widely accepted and generally known by neuropsychologists and psychologists that when you do that, there is a high probability that the examinee is going to likely score a little bit better the second time just because they've had experience with this test, particularly on a test like the Wisconsin card sorting test where there are really just a few different concepts that solve the test. And so once you know what those concepts are, then taking it the next time is a breeze.
Now, isn't this the test where it changes constantly, though? Like, then the person has to change their ability to explain the test to us.
There is, yeah. I don't want to be too specific because I'm bound by ethics in terms of disclosing, the paradigm of a given test. But yeah, there is a change. The rules change, but the individual is able to figure that out by the feedback that they get about whether they are right or wrong. So there's nothing unfair about it, and it's it's the kind of thing that we all deal with in daily life, where we're confronted with problems and that we try to solve that problem, and we find out that our solution isn't going to solve it. And so we have to come up with a new solution. And then we find out whether that solution works or not. So that's kind of what the Wisconsin card sorting test is how it's structured.
Okay. And does that mean this practice effect, does that mean somehow invalidate the second set of tests or the third set of tests? Or is that just something you have to take into consideration when looking at the test results and scoring it?
It doesn't, in my opinion, it doesn't invalidate these kinds of tests. You just need to take that into consideration and realize, particularly if you know that he performed in the average range and demonstrated essentially intact executive functioning, at least as assessed by the Wisconsin card sorting test, then you'd expect him to do better. That kind of expectation is being confirmed through his higher scores the second time.
Okay. How about the rest of the tests of executive function?
The category test is another widely used, very good test. I did not administer it the first time I saw him. Dr. Manguso did when she saw him. I then re-administered it. Like the Wisconsin card sorting test, Mr. Holmes showed a very robust practice effect the second time, or when I administered to him after he'd already been exposed to it, which was no surprise. Trail making B is actually a complex test that is speeded. You have to do it fast. And he scored actually in the low average range when I evaluated him originally. He then did better when Dr. Manguso evaluated him, and then he dropped back down to his original level of performance when I evaluated him the second time.
Okay. And the other tests there?
That's true. All these other tests they're different ways of assessing different aspects of executive functioning. Mr. Holmes consistently is scoring in the average to high average range on all these tests. These are not tests that Dr. Manguso gave. These are tests that I gave to him, and he's demonstrating intact executive functioning on all these tests.
Okay, so consistency over time on these domain, and generally intact?
Yes.
And what does that mean about his cognition?
Well, it means that in these various aspects of executive functioning, and I think it's important to keep in mind that executive functions are a very broad range of higher order mental abilities, as Dr. Manguso described yesterday, that Mr. Holmes is demonstrating consistently that these abilities are preserved in him, and that he possesses these kinds of functions, and they're generally intact.
Okay. Next, I'd like to talk about intelligence testing, and this was a type of testing that Dr. Manguso didn't do because you'd already done it, I think, is what she testified. Do you remember that testimony?
That's correct.
Can I have slide 5, please, ma'am? Now, what's this slide about? Is this kind of how we rate people based on their IQ?
Yes, this is the distribution of intelligence, of intelligence as it is assessed by psychologists, and as how it's been kind of conceptualized or defined by psychologists, particularly in North America. And it is, if you look at the center where it says 90 to 109 is the average range.
Okay, so is it like 100 the average, basically?
Yes, 100 is the average full-scale IQ for Americans.
And below 70 there, would that be what was commonly called, developmentally delayed or mentally retarded, something along those lines? Somebody who's to that degree?
A score below 69, or score 69 and below, historically would be an IQ that would be in the range of mental retardation. That's not a term that's America.
And Mr. Holmes' score was a 123 in April?
Yes, Mr. Holmes achieved a full-scale IQ of 123, which is at the 94th percentile, meaning that compared to other, at that time I believe he was 25, so comparing him to other 25-year-old males, he was, at least based on a test like the WAIS-4, he would score higher than, he would score at or above 94 out of 100 people.
Okay. And what's a full-scale IQ?
The full-scale IQ is the total score, the grand score that represents total intellectual function. And I think it's important, however, as Dr. Manguso mentioned yesterday, intelligence doesn't comprise all mental abilities. It's actually a relatively limited set of cognitive functions that constitute intelligence as defined by psychologists in our culture. There are other functions other mental functions that are not part of intelligence, but it certainly has been demonstrated over many, many studies and many, many years that intelligence is highly predictive of certain aspects of performance in our culture.
Okay, thank you for that. Is the full-scale IQ the combination of the verbal IQ and the nonverbal IQ, or the mean of the two?
It is, and there are also other factors, other IQs or indices that also are factored into the full-scale IQ in addition to the two that you just mentioned.
Okay, and are those factored in by the WAIS itself, by the test itself, and the scoring of the test?
By the scoring of the test, yes.
Okay. May I have slide 8, please? Now, what does this slide reflect?
This slide reflects the comparison between the first evaluation that was conducted of Mr. Holmes in April of 2013, where he achieved a full-scale IQ of 123, and that is then compared to the second evaluation that I did in January of 2015, where his IQ declined from the superior range with a score of 123, the 94th percentile, down to the full-scale IQ of 116, which is at the 86th percentile and is in the high average range.
Now, I want to just talk generally about that. The 123, that's obviously got some ways to go before we reach a genius level of what you described as a 140, or is that correct?
Yes.
Nevertheless, a 123, that's an intelligent person. That's a high IQ. Fair to say?
That is superior intelligence.
Okay. And that means that 93% of the people in his particular group that are his age with his education have a lower IQ than that. Fair to say?
True.
Now, in January of 2015, he got a 116. That's still smart, isn't it?
It is.
That doesn't mean he can't think, right?
Of course not.
But it bumped him down into the high average range. Can you tell us a little bit about that? What's the significance of this?
Well, the significance is that it is a significant decline or a significant change in a negative direction, and it is an unusual and abnormal change to see in an individual between the ages of 25 and 27, so it warrants interpretation. Somebody like me has to determine what is the reason for this change.
Okay. What's a standard deviation?
What is a standard deviation? Well, technically, a standard deviation is the square root of the variance, but I'm sure that's not what you want to hear.
I can hear it, but I don't understand.
A standard deviation is a psychometric property that shows the amount of dispersion or the amount of variability of scores around the average score. And standard deviations then are used to mark how far a given score is from the average score, either going down or going up.
Okay, thank you. May I have slide 9, please? What do we have here? Looks like it's broken down, the IQ, is that right?
Yes, this goes back to a question you asked a few moments ago about the different scores that go together to produce the full-scale IQ. And this lists his full-scale IQ in April of 2013, which was 123. And these four scores below, the perceptual index, the verbal index, it's a working memory index, and a processing speed index. Those four scores they go together they are calculated together to determine what the full-scale IQ is. And in this case...
I'm sorry, I don't mean to interrupt you. Were you done?
Go ahead.
I use the terms verbal IQ and nonverbal IQ. Are those kind of represented by the perceptual index and the verbal index?
Yes, the perceptual index would be what could be called the nonverbal IQ, and the verbal index is commonly referred to as the verbal IQ.
Thank you. Slide 10, please. And is this the second set of testing with the same breakdown?
Yes.
And what was the distinction here?
The distinction here is then to demonstrate that Actually, with the exception of the verbal index, Mr. Holmes showed some evidence of decline in all of the other indexes. The primary one where he showed quite significant decline was the perceptual index, which decreased from a score of 127 in April of 2013 down to a 113 in January of 2015. And that is certainly a major change, a significant change. There were also declines in some of the other factors, but they weren't as nearly as strong or as robust as the decline in the perceptual index.
Well, slide 11, please. Does this show those breakdowns? Are these acronyms for those same terms on the left here? The FSIQ, full scale IQ, the PRI, the nonverbal, the verbal, the third one. Is that right?
Yes.
And does this show that what you were just testifying about, that change?
Right. This shows the same numbers and then the amount of change and the direction of this. So it was a decrease of 7 points, a decrease of 14 points. As I said before, he actually increased a little bit on his verbal intelligence in that interim. And then some small decreases then in the other two indexes.
Let me ask you a question, and answer this if you can. Because if Mr. Holmes were to spend a lot of his time in the jail reading, might that be a factor in why his verbal IQ maintained the level and even increased 2 points? Would that be a factor or not?
I think that's a reasonable factor. Mr. Holmes is a voracious reader, and reading a lot can increase vocabulary, and it can increase the amount of semantic information that you have available to you. And I think that's likely why that score is increased.
Can I have slide 12, please? Now, to be fair, this has some overlap with the last slide. A lot of overlap with the last slide. What's different is that you put the percentiles in there. Is that right?
Yes.
Now, that non-verbal IQ from the 96th percentile to the 81st percentile, is that a full standard deviation from the mean?
Well, it's almost a full standard deviation. The standard deviation for the full-scale IQ and the index scores is 15. So he had a decline of 14 IQ points, which that almost then is a full standard deviation of decline.
Is that something that's unexpected in a man who's otherwise healthy physically in his early 20s?
That is unexpected. It's very unusual outside. It's certainly very unusual in it's abnormal. It's not something that would be expected in a normal person. It is strongly suggestive of some kind of pathologic process.
Now, you've indicated that you've done neuropsychological evaluations of individuals who have later been diagnosed with schizophrenia. Can schizophrenia cause a decline in cognitive function or IQ based on your experience?
Yes.
How does that happen? Or how can that happen?
Schizophrenia and the schizophrenia spectrum disorders in general are characterized by progressive changes in the brain, and in some individuals with schizophrenia spectrum disorders who over time will show decline in some cognitive functions, intellectual functions. Some people with schizophrenia spectrum disorders show global cognitive dysfunction. And in fact, many people with schizophrenia with schizophrenia specifically, show global cognitive dysfunction, up to 1.5 standard deviations below their peers.
Now, we certainly don't have that here, do we?
We do not.
Okay. Nevertheless, is this significant in that regard?
It is the declines that he showed with regard to his nonverbal IQ in particular is abnormal and significant.
And I want to be perfectly clear what we're saying here. Are you saying that because these tests declined, that he has a specific diagnosis of schizophrenia or a schizophrenia spectrum disorder? Can we say that, or is that just not realistic?
No, I'm not saying that at all.
Okay. You're not saying he has schizophrenia, or you know what his diagnosis is, fair to say?
That I know what other doctors have diagnosed him with, but these test data do not diagnose him with anything.
Okay. Could be consistent with schizophrenia, could be consistent with other things as well, fair to say?
True.
Can I have the slide 13 now, please? What's this? What are we showing here, sir?
This is a lot of data. This is showing the subtests from the Wechsler Adult Intelligence Scale, 4th edition.
Okay.
And they're just laid out. They're not. They're not specified in terms of which index they go to. I can tell you the vocabulary, information, and similarities. Those are the 3 subtests that comprise the verbal intelligence index. Block design, matrix.
And that was the one where he actually increased by 1 point, is that right? Because he had a +1, +1, and a -1.
That's right. His vocabulary increased by 1 point, and his information, which was his knowledge base, increased by 1 point.
Okay. And the next 3?
Then
or the next group?
Block design, matrix reasoning, and visual puzzles are all subtests that comprise the perceptual reasoning index, or the nonverbal intelligence.
And that was the larger drop there, the 14-point drop.
Right.
And then below that?
Below that, arithmetic and arithmetic and digit span are the 2 subtests that constitute the working memory index. And then the symbol search and the coding subtest constitute the processing speed index.
Now, you can take that down, ma'am. Thank you. Have you seen circumstances where you've done neuropsychological testing that showed some deficits or decline, and doctors have subsequently ordered some kind of a brain picture to be taken? Can that brain picture reflect perhaps, or can that brain picture show things that are congruent with such a decline in neuropsychological testing?
Yes. The objection is sustained.
Could I have slide 14, please? This is a different domain memory,
Yes.
and was this also, this looks like the same name, Wetschler up there. Is this different than the waste, though?
Yes,
Is that the guy that came up with the tests?
it is.
And what's this test about?
This test is a very widely used test of memory function that's been around for 70 years and various versions. This is the most recent version, the fourth edition of this test. It's very widely used, again, in the English-speaking world. And it consists of primarily two domains of memory that are assessed: verbal memory, so your memory for information that comes in word form, whether it's a story, for example, or whether it's a list of words that the examinee is asked to remember. And then the other side, the other domain of memory involves nonverbal memory. So it's memory for different patterns and spatial locations.
Okay. And how did he perform on the two different occasions that you tested him in the domain of memory?
His verbal memory, the first time I evaluated him was, although within normal limits, the two on the top where it says log-mem1, log-mem2, that stands for logical memory 1, logical memory 2. That involves hearing a story and trying to remember it, and then being asked to recall that story at a later point in time. Excuse me. And he scored in the low average range when I evaluated him in 2013. When I reevaluated him in 2015, he had improved a bit. Part of that is clearly due to practice effect, because these are tests that are extremely vulnerable to the effects of having previous exposure to them. So he showed some increase there. Then if you look down below where it says Designs 1, and then there's Content 1, Spatial 1, and Designs 2, Content 2, Spatial 2. Those are tests and sub-tests of nonverbal memory. As I said before, the kind of visual patterns and spatial location. And he did show some significant decline in that aspect of memory, which again is unusual and abnormal, again, for someone in the range of 25 to 27 years old. You should either stay the same or go up a little bit due to practice effect, but this consistent decline was unusual.
And let's talk just very briefly about practice effect and the results of this testing. If I'm understanding correctly, because he took the tests before, the second time he took the tests, the practice effect should make the score higher to some degree. Is that right?
It should. It may be a slight increase, or it may be a significant increase.
But his score went down. His intelligence went down.
That's correct.
Shouldn't we adjust it down more for the practice effect, or is that not fair? You know what I'm saying? If it should have gone up 2 points and it went down 14 points, shouldn't we account for the 2 points it shouldn't have gone up?
That is the standard practice in assessing the significance of that kind of change in scores, is to take into consideration the practice effect. So, yeah, that is usually done in the clinical interpretation of such scores.
Okay. And did you take that into effect?
I did.
And what's your opinion about the practice effect? Does that change anything?
The practice effect would estimate that his scores on again back on the intelligence testing would be a little bit higher the second time than the first time. Again, he's functioning at a very high level to begin with, so he can only go so much higher, but he can go a little bit higher. So, for example, he had a full skill IQ of 123, and that given that, you would expect that his full-scale IQ, the next time he takes that test, is going to be a few points higher.
Like 125?
Or maybe even higher than that, maybe 127, 128.
Does that make the decline even more significant then?
It does.
Overall, sir, based upon your testing that you did in April of 2013 and in January of 2015, and the testing that you know Dr. Rose Manguso did 4 months later in 2013 after your testing in April, what are your general impressions or conclusions about the neuropsychological state of Mr. Holmes?
My general impression is that in many domains of mental function, mental ability, and again, all I'm referring to are cognitive functions and intellectual functions, that he remains stable in many domains, such as executive functions, language functions, most attentional abilities, but he shows an unusual and abnormal decline in nonverbal intelligence specifically, and that involves nonverbal perceptual or spatial types of abilities, constructional abilities, being able to perceive things, be able to do things and process information quickly, which is a classic feature of schizophrenia spectrum disorders. So in my overall opinion, his neuropsychological profile and the difference between the two times, particularly also factoring in that Dr. Manguso saw some subtle deficits even 4 months after I saw him, that kind of trend, that type of decline that he's showing is, again, not diagnostic of schizophrenia spectrum disorders, but it is consistent with what we know about the changes that occur in some individuals with schizophrenia spectrum disorder.
Okay. And to be clear, there's nothing about the testing that you did that suggests that in 2012 Mr. Holmes was incapable of driving, going through normal life, going to a store and buying weapons, for example, and going into a theater and shooting people. Fair to say?
He clearly was capable of doing those things.
No indication that he was mentally incapable of doing those things, is there?
There is not.
Does your neuropsychological testing, though, tell us anything about whether or not he was psychotic or suffering from a psychiatric disorder during that period of time?
No.
And if I may have one moment, Your Honor.
You may.
Now that decline in IQ, can that be attributed to the fact that Mr. Holmes is sitting in jail and not doing anything other than reading books? Does that account for that big of a drop in IQ?
No, that is not going to account for that big of a drop in IQ, particularly in light of the fact that he doesn't show decline in most other areas of cognitive functioning.
Okay. Was Mr. Holmes on medication when you performed your testing, both in 2013 and in 2015?
Yes.
And what medication was he on? Do you know?
Yes.
Tell me.
He was on Risperdal, also known as risperidone.
Is that an antipsychotic?
That is an atypical antipsychotic.
And to be fair, you're not a medical doctor, are you?
I am not.
You can't prescribe medication, can you?
I cannot.
Do you have to have some knowledge of what these medicines do in order to be able to accurately conduct your testing, though? Is that part
Sure.
of your expertise?
Better.
What else was he on? What was the second thing?
So in addition to Risperdal, the antipsychotic, he's also on a drug called Lexapro, or also called escitalopram, which is an antidepressant. He's also on a anticholinergic drug called Cogentin, which is commonly prescribed in collaboration with an antipsychotic medication to prevent some of the what are called extrapyramidal effects that occur with some antipsychotic drugs. There are things like motor abnormalities, tremors, and motor rigidity, those kinds of problems. So that's an important drug to administer. And then the second time those were the three drugs that he was on. The first time I evaluated him, and on the second time I evaluated him, he was on one additional drug called Vistaril, which is also called hydroxyzine. That's an antihistamine.
Let's talk about the three that he was on both times. Could those have affected the testing?
In my opinion, that's not. There's no reason to expect why those drugs would have affected his test performance. The Risperdal has been demonstrated repeatedly to actually have a beneficial effect on.
Sustained, and he already answered the question anyway, so ask your next question, please.
How about Vistaril, the drug that was on the second time? Is that something that you have to be aware of in administering these tests, the effects of Vistaril possibly?
I think you certainly need to be aware of it. It is an antihistamine drug. It has many different effects, but it does have, as an antihistamine, it does have a sedative effect at certain doses.
All right, next question, please.
May we approach, Judge?
Yes. All right, Mr. King, you may proceed.
Thank you. With regard? Does that have any effect upon the result
it is possible, even though in reviewing all the test data, because I was certainly concerned about that, I don't think it did, but it certainly needed to be examined and considered.
Okay, so,
True.
okay, with that,
No.
thank you, I don't have any other questions.
All right, thank you. All right, members of the jury, it's a little bit after 12, so let's go ahead and take our lunch break. Please keep in mind all my admonishments during the break, they all apply. Let's take an hour only. There are some witnesses who have to testify today, and so I want to make sure that we don't run out of time, and that if at all possible, I don't keep you here late. So if it's okay with everyone, let's have you back in 1 hour, okay? All right, thank you. The record should reflect that the jury has exited the courtroom. Let's take our lunch break, and I'll see everyone back here in 1 hour. Thank you. The court will be in recess.
Please rise.